This conference will now be recorded.
Okay, so today we will be discussing two talks of July, July 2017. One is regarding induction of labor, that is the overview of past, current, and future methods of cervical ripening for induction of labor, and another is cystoscopy for gynecologists. So this cystoscopy talk is very small, okay, and there is no need to go into the procedural detail, but you should know only the indications, contraindications, and the risk associated with it. So this is the very short talk, so I have included this with the induction of labor. So first we will see this induction of labor talk today. So what do you mean by cervical ripening? So before labor, cervix usually undergoes a process of softening, effacement, and then dilatation, which is known as cervical ripening. It is a physiological continuous process. Okay, it is not that first softening will occur, then effacement will occur, but no, this occurs in continuum. So it occurs throughout the later weeks of pregnancy, and it is completed with onset of labor. So there is a continuum from unripe to ripe, or from unfavorable to favorable. So how you are going to judge this cervical ripening is the Bishop's score. You all know. Okay. So there are two types of scores. Bishop's score. One is original Bishop's score, and another one is modified Bishop's score. So what is the difference between these two is? So in 1964, Bishop devised the score on the basis of 5 points. So which are these 5 points? Is cervical dilatation, effacement, station, cervix consistency, and position of the cervix, where the maximum score is 13. Okay. Now, what happened with modified Bishop score? It is also known as Calder score. In 1974, this Bishop scores was somewhat modified. Now, what is that modification is? The only what is a change is effacement is somewhat difficult. If you describe it in percentage, it will be observer dependent relation effacement. So it depends on observer, so variations will be there. So for this effacement, they have substituted it with cervical length. So it is Calder's modification of this Bishop score. So here they have just changed this cervical length for the effacement. So 1 in 5 pregnant women in high income countries, they have induced labors. Despite the variety of methods available, no method is optimum. So now what are the common methods for induction of labor? Now in this talk, they have given in detail regarding the history of all this induction, like how they have started. First, they used to do this amniotomy, then they used to do forceful dilatation of cervix, castor oil, and all these things. But these are all historical aspects. No, you should not go into that much detail. So I have just taken what is the important part of this talk. What are the common methods of induction that are the used? So first of the is membrane sweeping. Now membrane sweeping is not a proper or formal method of induction, but it is the thing that you should do before any induction of labor. So what is this membrane sweeping? It involves vaginal examination during which a finger is passed through the open cervical os, and the finger is circumferentially rotated so that the choriamniotic membrane will be separated from that residue of lower uterine segment. Now, if the os is closed, if the cervix is closed, then cervix can be massaged through the vaginal fornices. So, if you massage the cervix in the vaginal fornices, it will exert the same effect to separate this membranes from the residue. Now, what this does? So, this it is associated with increase in local prostaglandin concentration, so which is known to induce the labor. So now, according to a nice guideline of induction of labor, prior to any formal induction of labor, women should be offered membrane sweeping. Okay, vaginal examination for membrane sweeping as an adjunct to formal induction. So now, what are the advantages of this membrane sweeping? So it is associated with higher rates of spontaneous vaginal delivery. So sometimes this membrane sweeping alone act as a labor inducer. Also, shorter induction to delivery interval, reduce likelihood of postpartum pregnancy, and decrease need for induction of labor. So if you want to avoid one induction of labor, if you want to avoid in one woman, you have to perform at least 8 membrane sweeps. Okay, so the ratio is 1:8, or number related to it is 1:8. Now, what are the undesirable effects of this membrane sweeping is discomfort after the procedure, vaginal bleeding, or irregular uterine contraction in the first 24 hours. So these are the undesired side effects. Now, this membrane sweeping, it does not increase the risk of maternal or neonatal infection. And even in case of group B Streptococcus, membrane sweeping is a safe procedure. Okay. So even GBS carrier females also, you can offer membrane sweeping. It will not increase the risk of POGBS to the baby. Now, second method is amniotomy. Now, amniotomy, it is a very less popular method for induction of labor. Why? Because the time interval between the amniotomy and onset of labor is very unpredictable. Now, when you want to use oxytocin for induction of labor, amniotomy should be always performed first. NICE does not recommend the use of amniotomy with or without oxytocin for the primary method of labor induction. So yes, augmentation, definitely according to NICE guidelines, you can use either amniotomy and oxytocin both, but for labor induction, either amniotomy or oxytocin is not recommended unless there are specific contraindications for this prostaglandins. Now, the cord prolapse is the major risk with amniotomy when it is performed with unengaged presenting part. So, cord prolapse is a major disadvantage if you do the amniotomy unengaged presenting part. Oxytocin titrated IV oxytocin, it is the commonest adjunct used for induction of labor and maintaining uterine contractions. This is a naturally occurring peptide from the posterior hypothalamus, and it acts on oxytocin receptors in the uterus, but no direct effect on the cervix. Oxytocin induction may increase the rate of surgical interventions in labor when the cervix is unfavorable. So it increases the rate of cesarean section or instrumental deliveries. Overall, oxytocin should be used judiciously as it is uncontrolled use. It is associated with hyperstimulation and FHR abnormalities that you know. Now, another thing is extraamniotic saline infusion. Yes, this was used for this termination of pregnancy in second trimester. Okay, so you know this, that it is extraamniotic instillation of this saline. It is used for the termination of pregnancy in later gestation. But for the IOL in third trimester, usually this extraamniotic saline was infused through a transcervical catheter. Infusion rates can vary between 30 to 60 ml per hour. What does it cause? It does same thing, that it will strips the membrane and increase in the local prostaglandins and other inflammatory mediators, which will induce the labor. Sorry. Now, according to Cochrane, actually, though, as you know, like if you instill anything through the cervical os, it will increase the risk of infection. But Cochrane review, they have concluded that there is no increased risk of infection along with this extraamniotic saline infusion. So theoretically, chorioamnionitis and endometriosis, these are the risks, but according to Cochrane review, there is insufficient evidence of this infection. So no systemic review support this concern. And also according to meta-analysis and Cochrane review, they have concluded that there is insufficient evidence to support the use of extraamniotic saline infusion for the induction of labor. But yes, it can be used along with Foley's catheter. So Foley's catheter plus extraamniotic saline infusion, this can be the thing that can be combined for induction of labor. But also other studies, they have not found out any benefit of using this saline along with Foley's catheter also. So one Cochrane review, they have found out that alone EACI is not useful, but it can be used along with Foley's catheter. But other reviews does not support this finding. Also, evidence of using this extraamniotic saline along with prostaglandin, these reviews are also conflicting only. So sometimes they have found out that sometimes there is some reduction in the delivery time, induction to delivery time, but other studies have not shown any such effects. But only thing, when used with prostaglandin, it improves the cervical scores. Okay, so Bishop score, it will increase, but finally they don't have a proper evidence that it will reduce the induction to delivery time. So again, this is not a recommended method for this induction of labor. Now prostaglandins, there are two things. You can use either PGE1, that is prostaglandin E1, that is misoprostol, or PGE2. So PGE2, it is available in different preparations like tablet, gels, and control release preparation, which is called as dinoprostol. So a meta-analysis, it is showed that compared to dinoprostol, misoprostol is likely to be superior for induction of labor. And lowest cesarean section rate is associated with titrated dose of oral solution of misoprostol. So lowest cesarean section risk is associated with use of misoprostol. Here they have not mentioned anything regarding PGE too much. Okay. Vaginal delivery within 24 hours of induction, it is most likely to be achieved when the misoprostol dose is used at the dose of either 50 milligram or more than 50, not milligram, 50 microgram or more than 50 microgram is used. But this is associated with other undesirable side effects like fetal heart changes and hyperstimulation. So you can use this 50 microgram of misoprostol according to reviews and meta-analysis. So it can be a reasonable option when the quicker delivery needs to be achieved and facilities for intensive monitoring, they are available. But there are no studies or there are no proper evidence how to titrate this dose and at what interval it should be given. So whether it should be given at 2-hourly, 4-hourly or 6-hourly doses. So further studies are required for that proper interval of doses. Now another method is balloon catheters. So it is a mechanical method. So placement of cervical balloon catheters. So these balloon catheters can be okay, BJ, from next time, sure. So these balloon catheters either can be single balloon or double balloon. Okay. So single balloon is routine Foley's catheter, and double balloon, right now new Cook's catheter is also available, and there are different types of double balloon catheters are also available. So they causes this mechanical stretching of cervix, which will release the local prostaglandins. Also, they have found out to increase the levels of interleukins and matrix metalloprotein, nitric oxide synthesis. So all these will help in the induction of labor or cervical effacement. Double balloon catheter is thought to be superior to Foley's catheter because the force of dilatation, see, you can see it is from the internal os also and it is from the external os. So double balloon catheter, there will be double effect from at the internal os and at the external os also, while cervical Foley's catheter only exerts its effect at the internal os. Okay. But when you compare the evidence, it suggests that there is no significant difference in delivery intervals or modes of birth when they use either single balloon or double balloon catheter. But one thing is there, the Scoop's catheter is a licensed method for cervical ripening, while Foley's catheter is not licensed for the use of this indication. Okay, so Scoop's catheter is licensed for cervical ripening, but Foley's catheter is not licensed for use of induction of labor or cervical ripening. Now, when you compare different balloon volumes, so balloon volumes, it is shown that higher volumes, if you instill, the favorable cervix will be achieved more quicker and more, it is likely to be achieved. Okay, but then again, it is not always, it is always shown in the evidence also. So, but yes, definitely the overall risk ratio is favorable to high volume Foley's catheters. But the rate of cesarean section is not different with that of low volume. Okay, but yes, somewhat faster achievement of the favorable cervix can occur. Okay, and then balloon traction, there is no difference at all between time of delivery and rate of cesarean sections or pain score or epidural analgesia. So balloon traction, it doesn't have any effect, but yes, balloon volume, some studies have shown that higher volume rates, they are associated with earlier delivery. Now, infection risk with balloon catheter. So some studies are there which have reported there is risk of infection is there with use of mechanical method. But when you collect the proper evidence, they whether this evidence support or refute this claim is passed, because there are very limited number of studies. So according to a 2012 Cochrane review, there is no evidence of an increase risk of infection with mechanical methods. But again, the author warns that interpreting this finding is should be in caution, because the evidence available is very limited. Also, meta-analysis of different 30 RCTs, it demonstrated an increased risk of infectious morbidity, but it is limited to the Foley's catheter use only. Okay. Now, when it is used with extraamniotic saline or dilators, then again the infection risk is somewhat less. But all these studies are having some methodology fallacies. So it's very difficult to interpret this result. So we don't have a proper evidence whether it increases the infection or whether it is not associated with increased infection risk. Now, if you want to use mechanical methods in case of pre-labor rupture of membranes. So when these mechanical methods are used, so usually the studies are available with intact membranes. But there is one study, a retrospective study is demonstrated that there is no significant increase in risk of chorioamnionitis when using intracervical balloon. But this is a single study and there are no proper studies to see that whether it is beneficial or whether it is associated with increased risk of infection. Now another method is osmotic dilators. So osmotic dilators or hygroscopic dilators, they have been previously used for this termination of pregnancy in advanced gestation. Okay, but now these osmotic dilators, they act by absorbing water from the cervix. So it dehydrates the cervix and making it soft and dry. When the dilator expands, it causes mechanical stretching and also release of this prostaglandin. So it is a double effect, that is dehydration of cervix and also stretching of the cervix. Now, as I told you, it was used with the advanced gestational age in termination of pregnancy, but with induction of labor, the available evidence is limited. One RCT is there which has used this, which has compared the dilators with prostaglandins, and they have found out that there is significantly higher rate of hyperstimulation. It is associated with PGs, that is prostaglandins. So Dilapan S or this is osmotic dilators, they can be used as an outpatient agent for IOL. If they want to use this, if the patient wants home-based induction, she doesn't want to get admitted to the hospital for induction of labor, then these osmotic dilators can be used as a method of induction because it does not require monitoring for this fetal heart. So what are the advantages of this mechanical methods like Foley's catheter for labor induction? So it is the lowest risk of uterine hyperstimulation and adverse FHR changes, lower in cost than dinoproston or the double balloon catheter. So now this is the advantage of Foley's catheter, remember it. Easier to store, less monitoring of uterine contraction is required. No further clinical intervention is required unless the catheter is expelled. More suitable for induction of women at the risk of which are at the risk of placental insufficiency or fetal compromise like preeclampsia or IUGR. So what happens in this? Because there is a high rate of hyperstimulation and CTG changes will be there. So for those women, this mechanical methods will be useful for the induction. There is no clear evidence of increased risk of infection or chorioamnionitis, and it can be a possible alternative for induction of labor who wants a home induction. Now, what are the advantages of low dose misoprostol? So it is associated with lowest cesarean section rate. It is cost effective, but still RCT is required to prove this. Easier to store than dinoproston because it does not require any temperature or something like that to store it. More acceptable to the woman because it can be orally administered and it is easier to administer. Now, after seeing all this method, finally, what the NICE guideline recommends. So, NICE guideline of induction of labor, it recommends that only PGE2, vaginal PGE2 is it can be used as a tablet, gel, or controlled release pessary for the first line. So, as a first line, PGE2 is the first line agent for induction of labor according to NICE guideline. Misoprostol should be offered as a method of induction of labor only to women who have intrauterine fetal death or in context of clinical trial. So for IUFD, misoprostol is recommended. For live fetus, dinoproston or PGE2 is recommended. Now, mechanical methods, it should not be used routinely for IOL. So I'm telling all the nice recommendations. Okay. Then RCOG guidance on VBAC, that is previous cesarean section cases, indicates that prostaglandin should be used with cautions because it is associated with increased risk of uterine rupture. So further research into the mechanical methods for IOL in VBAC patient, it is required. So this is regarding this IOL talk. So these are the questions. You can type in the chat box your answers. So first question is 30-year-old gravida to caravan is seen at 41 weeks of gestation to plan and book for induction of labor on account of her death. She is known to be a group B beta hemolytic streptococcus carrier. What would be the next logical step to take into her management? Yes, because membrane sweep is not contraindicated for group B, correct? GBS carrier. So answer is E, offer a membrane sweep and give a date for induction of labor. This is the answer. Next question. Titrated oxytocin is now the commonest adjunct used for induction of labor and maintaining uterine contraction. What is the mechanism of action of this uterotonic? Now this is the easiest one. Yes, so it binds to the oxytocin receptors, which causes myometrial contraction. Answer is C. Next is cystoscopy talk, that is cystoscopy for the gynecologist, how to do a cystoscopy. Now, as I told you, they are given in detail regarding how to do rigid cystoscopy and how to do flexible cystoscopy, but it is not at all required for you to know the procedure. But yes, you should know what are the indications, what are the contraindications, and what are the risks, and when to refer the patient. So this is the most important thing of this. So cystoscopy, it is the endoscopy examination of urinary bladder and urethra. It is performed using either a flexible or rigid cystoscope under local or general anesthesia. Indication. So indications for cystoscopy are visible and unexplained hematuria, that is frank hematuria, either without UTI or which persist after successful treatment of UTI over 45 years of age. Visible or unexplained hematuria with a raised WBC counts when the age is more than 60 or more. Unexplained dysuria, non-visible hematuria above 60 years, recurrent UTI, bladder pain syndrome, voiding symptoms, vesicovaginal or colovesical fistulae, urethral stricture, and congenital genital tract abnormalities. Now, as a part of other surgeries, cystoscopy is done for mid-urethral slings and colposuspension, intravesical Botox injection, and staging of gynecological cancers. Contraindication, the only contraindication for cystoscopy is untreated UTI. Remember, well, this can come as a question routinely. So only contraindication for cystoscopy is untreated UTI. Risk of cystoscopy. So the common risk is mild burning or bleeding on passing urine for a short period. And also occasional risk are infection of the bladder requiring antibiotics. Rare risk is temporary insertion of catheter because of voiding difficulties. Delayed bleeding requiring removal of clots or further surgery. Injury to urethra causing delayed scar formation and stricture. And very rarely perforation of bladder which requires temporary catheter or open surgery. Now, what is the role of antibiotics? So for rigid cystoscopy, single dose of IV gentamicin is given before they are at the induction of anesthesia. And for flexible cystoscopy, routinely antibiotics are not required, but they are given in selective cases like intravesical Botox injection, women with recurrent UTIs, or if or as a like mechanical heart wall prosthesis. Okay. Now this is the assembly for rigid cystoscopy. I don't think it is required for you, but yes, it is required for part 3. Okay. So, and this is the flexible cystoscopy. Now, rigid cystoscopy, it is performed in the operation theater under general or spinal anesthesia, because you can see the scope is larger. Okay. So it requires the anesthesia. While flexible cystoscopy, it is most commonly performed in the operation department or ambulatory settings. You can see this cystoscope. So here, this is narrower than the rigid cystoscope and it is used under local anesthesia. Here, all areas of bladder can be visualized without changing lenses. One disadvantage is that of this flexible cystoscopy is only small biopsy forces can be used for the taking biopsy. Okay, so it provides smaller biopsy samples. Now, whenever you do cystoscopy, you have to record findings. You have to do it systematically and you have to record the findings systematically. So this is the drawing that you can use. So here it is the, see, it is the this is the trigon area basically. Both ureteric orifices, interureteric bar, and then these are different walls. Okay, and you have to explain the findings on this diagram. Okay. Now, when to biopsy? So when gynecologist can biopsy, take the biopsy, and when you have to refer the patient. So where biopsy is indicated where the histology will aid the diagnosis and treatment, like urothelial abnormalities or lesions, and in some cases of interstitial cystitis. So these are the cases, mild cases of interstitial cystitis or any urothelial abnormalities, that is epithelial abnormalities, that you can take biopsies. But whenever you are suspecting any cancer, suspected bladder cancer, visible hematuria, or cystoscopy suggests that it is a suspected cancer, then you should directly refer this patient for urgent urology review, and you should not take the biopsy in such cases. So, suspected cancer and visible hematuria, you are going to send this patient to urology review, while you can take the biopsy in case of interstitial cystitis or any minor abnormalities. So this is regarding cystoscopy talk. There is no strategy question on this talk. Okay. So this is for today. Tomorrow we will do I think tomorrow we will not do any talk. We will meet on Monday. Okay. So bye for now.